All right, welcome back to Discussions with Dr. G, where we are discussing medications affecting the reproductive tract. I'm Dr. G, your sarcastic guide through the hormonal jungle. Today's episode, Hormones, Pills, and Practicalities, which honestly sounds like the title of a daytime soap opera, but I promise there's less melodrama and more pharmacology. So let's kick things off with the big players. Estrogens, progesterones, and androgens. These are the hormones that basically run the show, whether you like it or not. Let's start with estrogens. You've got your estradiol, oral, transdermal, you name it, and conjugated estrogens like Premarin. We use these for hormone replacement therapy in menopause, for hypogonadism, and in some cases, even for certain prostate cancers. And of course, they're a key ingredient in a lot of hormonal contraceptives. But, as with all things in life, there is a catch, or several. Nausea is a classic because nothing says femininity like feeling queasy all day. Then there's the big one, thromboembolic events. We're talking DVTs, PEs, stroke, the whole clot parade. And if you give estrogen without progesterone to someone with a uterus, you're basically inviting endometrial hyperplasia and potentially cancer. So yeah, don't do that. Contraindications? There are plenty. A history of clots, estrogen-dependent cancers, liver dysfunction, pregnancy, just to name a few. And if your patient smokes, especially over the age of 35, the clot risk goes through the roof. I mean, it's like playing pharmacologic Russian roulette. And don't forget, some anticonvulsants can lower estrogen levels, so always check those med lists. Now, progesterones, medroxyprogesterone, norethindrone, micronized progesterone. These are your go-tos. They regulate cycles, prevent endometrial hyperplasia when you're using estrogen, and treat things like endometriosis and abnormal bleeding. But again, side effects, weight gain, because why not? Depression, fatigue, and yes, more clot risk. If your patient has a history of clots, liver disease, breast cancer, you're going to want to steer clear. And fun fact, rifampin can make progesterone less effective. Because again, why not? Androgens, also known as testosterone, mainly are used for male hypogonadism, delayed puberty, and interesting, some breast cancers in women. Watch out for hepatotoxicity, edema, polycythemia, and in women, virilization, which is where you start to look like a man. Think hair on the face with a deepened voice. Contraindicated in prostate or male breast cancer, and obviously pregnancy. Oh, and if you're using gels, make sure patients know not to accidentally turn their partner or child into the Hulk by transferring testosterone. Use gloves and wash hands, even at home, guys. Let me throw in a quick case study. Picture this. You've got a patient with brutal menopause symptoms, hot flashes, vaginal atrophy, the works. Estradiol patch seems like a miracle, right? But she's got a history of DVT. Suddenly that miracle looks more like a lawsuit. You have to balance symptom relief with the very real risk of clots. It's a tightrope walk, and honestly, sometimes it feels like you need a law degree just to prescribe HRT, which is hormone replacement therapy. Oh, right. Always double check what your patients actually understand. Trust me. Now, let's slide right into the world of contraceptives. We've got combined oral contraceptives, ethinyl estradiol plus norethindrone, and progestin-only pills, also known as the mini pill. These are the bread and butter for pregnancy prevention, but they also help with cycle regulation, acne, and premenstrual dysphoric disorder, PMDD. But, as always, there is a catch. Nausea, breast tenderness, hypertension, and you guessed it, more clot risk, especially if your patient is over 35 and smokes. That combo is basically do not pass go situation. So what do you do when you're counseling a patient over 35 who smokes? Well, combined contraceptives are out. The clot risk is just too high. You'll want to look at progestin-only options or maybe even non-hormonal methods. And don't forget to talk about backup contraception if they're on enzyme-inducing meds like certain antibiotics or anticonvulsants, because nothing says surprise like a missed pill and a positive pregnancy test. Emergency contraception is another hot topic. Levonorgestrel, also known as Plan B, needs to be taken within 72 hours of unprotected sex. Ulipristal, on the other hand, gives you up to 120 hours. But here's the kicker. Ulipristal is contraindicated in known pregnancy, and both can cause nausea, vomiting, and irregular bleeding. Oh, and neither will terminate an existing pregnancy, so make sure your patients know that. Timing is everything here, so the sooner, the better. Quick example. Let's say a patient comes in 96 hours after unprotected sex. The levonorgestrel is off the table, but ulipristal is still an option. But if she's late for her period, you need to check for pregnancy first. And as always, clarify that emergency contraception is not an abortion pill. All right, let's not leave the guys out. Men's meds. This is where things get interesting. We've got androgens, which I already touched on, but let's talk about 5-alpha reductase inhibitors like finasteride or dutasteride. These shrink the prostate in benign prostatic hyperplasia and at lower doses help with male pattern baldness. Side effects. Decreased libido, erectile dysfunction, and everybody's favorite, gynecomastia. This is where your guy grows breasts. But here's the big safety pearl. These meds can harm a male fetus if handled by pregnant women. So, if your patient's partner is pregnant, she should not be anywhere near finasteride tablets. Then there are the alpha-1 antagonists, tamsulosin, alfuzosin. Those help with BPH symptoms by improving urine flow, but they can cause hypotension, especially with the first dose. So, give it at bedtime and warn about dizziness. And if your patient is also on a PDE5 inhibitor like sildenafil or tadalafil, watch out for added hypotension. That's a recipe for a faceplant. Speaking of PDE5 inhibitors, Viagra or sildenafil and Cialis, otherwise known as tadalafil, all those commercials during football games, right? They're for erectile dysfunction, but also pulmonary hypertension at low doses. Side effects include headache, flushing, and the big one, priapism. If an erection lasts more than 4 hours, that's not a bragging right. It's a urologic emergency. I once had to explain priapism to a room full of giggling nursing students. Let's just say it was a long 4 minutes. And please never combine these with nitrates. That is a one-way ticket to the ER for severe hypotension. So, to wrap it up, whether you're dealing with hormones, contraceptives, or men's meds, the key is always patient education and safety. Ask about smoking, age, and clot history. Clarify drug names and types because, trust me, patients mix them up all the time. And document everything. The reproductive system is never boring, and neither is pharmacology. That's it for today. Catch you next time for more medication mayhem.